Hello, and welcome to the American Medical Association's webinar addressing respiratory virus outbreak prevention and response in long-term care facilities. This webinar was developed jointly with the Centers for Disease Control and Prevention's Project First Line initiative. Project First Line provides innovative and accessible infection control education for all frontline healthcare personnel. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. In our past PFL webinars on respiratory virus season, we have gotten an overwhelming number of questions about the specific challenges that healthcare professionals face in long-term care facilities. We don't usually have the time to get into the details of this population, so this year we wanted to devote an entire webinar to long-term care. We know that long-term care residents are at high risk of acquiring respiratory virus infections and developing severe disease. Our goal today is to walk you through the process of preparing for, recognizing, and testing for respiratory viruses, and the steps of responding to respiratory virus infections and/or outbreaks. We will also responding to respiratory virus infections and/or outbreaks. We will also highlight key health resources for you as healthcare professionals, but also ones you can share with residents and their families in long-term care facilities. We have some great speakers and experts in this topic, and while we aren't able to take live questions today, you all sent in some fantastic questions that we will address at the end. Let me introduce our speakers. Kara Jacobs-Slifka is an infectious diseases physician, medical epidemiologist, and commander in the United States Public Health Service. In her role at CDC, she leads the long-term care team in the Division of Healthcare Quality Promotion and focuses on improving infection prevention and containing and preventing the spread of infectious pathogens in the post-acute and long-term care settings through collaboration with health departments and partners, guidance and education material development, and outbreak response. Pragna Patel is a Chief Medical Officer in the National Center for Immunization and Respiratory Diseases at CDC. Dr. Patel has contributed to CDC responses for HIV, H1N1, Ebola, H5N1, and seasonal respiratory viruses. She's a board-certified physician and has provided care at the Atlanta VA Infectious Diseases Clinic since 2004. She is an adjunct assistant professor of medicine with Emory School of Medicine and an adjunct professor of epidemiology at the Emory University Rollins School of Public Health. Captain Janelle Ruth graduated from the University of California, San Francisco, UC Berkeley, Joint Medical Program in 1998 and UCSF Pediatric Residency Program in 2004. Her CDC experience has spanned food and waterborne outbreaks, cholera prevention in Haiti, acute flaccid myelitis, and polio. She recently returned from Malawi as the CDC resident advisor to the President's Malaria Initiative and is now the Associate Director for Medical Affairs in CDC's Immunization Services Division. Before we begin, I have 3 disclosure slides to show related to the CE that is being offered through CDC's Train Learning Network. We will advance through them slowly to allow you time to read them. The first is the following accreditation statement. This webinar is accredited for the following CEUs: CME, CNE, CEU, CHES, MCHES, CPE, and CPH. I will now share with you the following disclosure statement. Please take a minute to read. I'll now share the following joint accreditation statement for pharmacy education. Again, take a moment to read. That concludes the CE disclosure slides. It's my honor and privilege to give this presentation over to Dr. Slifka. It's all yours.
Thank you so much, Dr. Kaufman-West. We are truly happy to be bringing this webinar to you all today. Next slide. Most of the resources and references discussed today can be found in the Viral Respiratory Pathogens Toolkit for Nursing Homes, which is located on the CDC website. This reference has helpful information within it, as well as links to all of the viral respiratory pathogen related information across CDC web pages. Next. Within a facility, infection prevention and control resources, policies, and education are needed to help protect residents, staff, and visitors from respiratory virus infections. Next slide. Today, we're going to talk about how facilities and providers can prepare for increased use of respiratory virus IPC measures during the remainder of this winter respiratory virus season, but also for future seasons, by offering recommended vaccines to residents and staff, allocating resources for infection prevention and control, or IPC, educating residents, staff, and visitors, monitoring community spread, and ensuring appropriate facility ventilation. Next slide. We're then going to talk about how to respond when a resident develops respiratory virus symptoms, including use of transmission-based precautions, testing and treatment, and monitoring for additional infections among residents and staff. Next slide. And then finally, we're going to talk about time-limited enhanced IPC measures that can be used when there is spread within the facility. Next slide. So starting with preparation, during fall and winter months, we know respiratory virus infection risk increases for everyone. Dr. Ruth is going to discuss vaccines a bit more, so we're going to jump into a couple of other important measures. Having adequate and accessible supplies of personal protective equipment, or PPE, will make it easier to adjust PPE for resident care when new symptoms develop. Adequate stock of face masks, N95 respirators, gowns and gloves in the sizes that are needed and the models that are needed for staff, and hand sanitizer are examples of necessary IPC supplies. PPE and hand sanitizer should be available throughout the facility on both day and night shifts. And in addition, staff should be properly fitted for N95 respirators via annual respiratory fit testing to maximize their protection. And I also wanted to share something from in-depth interviews that we performed last year with nursing home residents and some of their loved ones. One of the things they communicated to us was that they felt an increased sense of safety and confidence within their nursing home community when they could see infection prevention practices taking place. So residents described that observing IPC practices being done in their presence, like staff cleaning their hands, wearing gloves and masks, and cleaning of common areas as well as their room, helped alleviate their worries about infection. Next slide. This is a resource that was developed for hospitals wanting to establish respiratory protection programs, but it has information that could be useful to nursing homes. It outlines the regulatory requirements for a respiratory protection program, and it includes links facilities can use to find local consultants to assist with activities like performing hazard assessments and performing fit testing. As a reminder, fit testing should be done annually, and anytime there are changes in either the respiratory supply or the staff member, such as a significant weight gain or weight loss that could affect the fit. Next slide. In addition to stocking PPE, it's important to identify how respiratory virus and other laboratory tests, like blood tests for kidney function, for example, can be collected and results available within 24 hours. Rapid test results can be most beneficial when pharmacy connections are also in place to ensure rapid antiviral access for residents with COVID-19 or influenza. And you will hear more about this and testing and treatment from Dr. Patel. Next slide. Now, I know we've been dealing with COVID-19 for the last several years, and people are in general pretty familiar with the recommendations. We understand that each day there can be many competing priorities for facilities and staff, from implementing enhanced barrier precautions to sepsis awareness and your many non-infection prevention responsibilities. As a result, it's important to remind everyone who enters the facility about recommended respiratory virus prevention policies, particularly if there have been any changes in practice as a result of an outbreak in the community or in the facility. This can include things like hanging posters describing respiratory hygiene and cough etiquette, or signs indicating when universal masking is in place. Annual staff refresher trainings around respiratory virus IPC measures like hand hygiene and proper PPE use can help ensure that everyone feels comfortable implementing the recommended IPC measures. Next slide. Another important aspect of preparation is to know when there's an increased risk of infection. Risk can vary by geography and facility population, for example. Regularly monitoring local indicators, your local indicators of increased community or facility respiratory virus spread can help you increase prevention efforts when the risk is highest. Your local or state health department can help you determine which indicators best represent increased spread in your community. And some examples of those could include things like the number of facility cases in a week, the percent of emergency room visits for acute respiratory illness in your county, the number of respiratory virus cases, hospitalizations, or outbreaks among the state's nursing home residents, or other local indicators. When community or facility spread increases, action steps might include things like universal masking, supplemental measures to improve ventilation, or increased surveillance among residents and staff for respiratory illness. Next slide. This is one resource from CDC that can be used to monitor respiratory illness activity in your state. It tracks information about emergency department visits, which when levels are high, might indicate that infections are making people sick enough to require treatment. It also tracks a measure of viral activity in the community through testing wastewater or sewage. Wastewater monitoring can detect viruses infecting people in a community, and when levels are high, it might indicate that there's a higher risk for infection. Next slide. NHSN, which is the National Healthcare Safety Network, is a resource that specifically looks at trends in nursing homes as one of the areas that they look at. And you can look at national and state trends that include case rates per 100,000 residents for COVID-19, influenza, and RSV. You can also look at national and state hospitalization rates per 100,000 nursing home residents for those same pathogens. Next slide. Finally, it's important to consult with your facility engineers to improve ventilation in resident and staff areas, including break rooms. And this can include things like achieving the number of air changes per hour that are specified by your state building codes and ASHRAE standards, developing policies around changing fan settings in rooms and clearing blocked vents. These are also an important resource when you're considering supplemental measures, like things like using a portable HEPA filter to help with the optimal placement and the function. And CDC has ventilation resources and FAQs that can help you and help inform some of those actions. Next slide. So now that the facility is prepared for the season, let's move on to responding to a resident's new symptoms, starting with a case example. So in this case, we have Mr. Jones. He's an 85-year-old man with a history of Alzheimer's and insulin-dependent diabetes. He lives in a nursing home and he shares a room with a roommate who also has dementia. It's January, and today, Mr. Jones' aide notices that he feels warm and he's got a new cough. But at this point, no one else on the floor has any symptoms. Next slide. As soon as a resident's new symptoms are identified, there are several steps that can help prevent further spread. This includes placing the resident on transmission-based precautions even before testing occurs. As a part of transmission-based precautions, next, move the resident to a single room, or if a single room isn't available, take steps to limit transmission within the room. An ill resident shouldn't be placed with a new resident or a new roommate unless both have already been confirmed to have the same respiratory diagnosis. Because a roommate has likely already been exposed, so in this situation, his roommate may have already been exposed, and they could go on to become infected, they also should not be placed in a new room with a new roommate. Next. The next thing you want to do is choose appropriate PPE. You want to use PPE based on the likely diagnosis. So some of the factors that you might consider include if the resident has had any known exposures to someone with a confirmed infection, and viruses that might be circulating within your facility already or within the community. By symptoms alone, we can't tell what is causing a resident's respiratory symptoms. The PPE used for SARS-CoV-2 protects against most common respiratory infections, and so in most circumstances, you'll use that while you're waiting for test results. Ill residents should remain in their room, and if they have to leave their room, they should wear a mask if they're able to tolerate doing so. Their roommate should also be encouraged to wear a mask whenever they are around others, just in case they develop infection. Next. Then you want to make sure to test the resident and investigate which close contacts might also benefit from testing and potentially antivirals. Next slide. So how could this apply to our response to Mr. Jones's new symptoms? Next. First, Mr. Jones' facility doesn't have any single rooms available. So the team places a HEPA filter in his room and separates the residents' beds as far apart from one another with a curtain drawn in between them. Next. A transmission-based precaution sign is posted outside of Mr. Jones' room, and a cart containing N95 respirators, gowns, gloves, and eye protection is placed outside of the door. Next. Mr. Jones is tested for SARS-CoV-2 and influenza, and close contacts, including his roommate and his aide, are evaluated for symptoms and for future testing. Next slide. Reassessment of transmission-based precautions, contact investigation, and resident treatment should occur when test results are available. So, for example, Mr. Jones is on precautions right now for SARS-CoV-2, which means his providers wear an N95 respirator, goggles, gown, and gloves when caring for him. If his influenza test is positive and his SARS-CoV test is negative, then he can be transitioned to droplet precautions, which refers to the use of a face mask. But if he's coughing, if the resident you're caring for in this situation is coughing and sneezing, then you would also want to wear eye protection to protect your eyes from splashes and sprays as a part of standard precautions. Next slide. As we mentioned earlier, residents on transmission-based precautions should generally be restricted to their room except for medically necessary purposes. If they leave their room, they should be given a mask and encouraged to physically distance. Transmission-based precautions are intended to be time-limited. The duration will depend on the cause of infection and in some circumstances also affected by the severity of illness, and if the resident is considered to be immunocompromised, which for some pathogens can mean they might remain infectious for longer. Information about the type and duration for different pathogens is available on the CDC website here in Appendix A. Next slide. As soon as a resident develops symptoms, they should be evaluated for treatment. If there's a strong suspicion for either COVID-19 or influenza due to a close contact or facility outbreak, for example, empiric antiviral treatment can be started before test results are known and then stopped if test results are negative. In the case of Mr. Jones, if we don't have a strong suspicion for the cause of his illness, we can still determine eligibility, availability, and dose of both a COVID-19 and influenza antiviral, and then as soon as his test results return, he can start the appropriate antiviral quickly. When his influenza test is positive, the team would then be able to start oseltamivir quickly. For influenza, unlike COVID-19, we have an additional opportunity to use chemoprophylaxis. So if Mr. Jones's roommate or other close contacts are asymptomatic, chemoprophylaxis dose oseltamivir should be started. While on chemoprophylaxis, Mr. Jones's close contacts should be monitored for symptoms and then testing performed if symptoms develop. Next slide. So as a part of your active monitoring for additional infections, you learn that 2 staff have called out sick with a fever and respiratory symptoms. One of them worked on the same unit as Mr. Jones and tested positive for flu at an urgent care. The other worked on a different unit but hasn't been tested. And then now there are some additional reports that are coming in of residents feeling feverish or developing sore throat and a cough. So testing is in progress. Next slide. By preparing for and quickly responding to respiratory virus illness, we aim to minimize spread within a facility. However, when a large degree of spread is occurring within a facility, time-limited enhanced IPC measures may be needed. Your local or state health department can help your facility determine which enhanced control measures are needed. Enhanced IPC measures might include broader testing and chemoprophylaxis, and you'll hear more about different treatment options from Dr. Patel. But in this situation, broader use of antiviral chemoprophylaxis in the facility may be indicated. Cohorting staff and residents, temporary modification of indoor visitation policies, things like encouraging in-room rather than common area visitation, universal masking, limiting communal activities like dining, and improving ventilation. And I do want to make an important note here. We recognize the toll that any form of isolation takes on residents. So any additional restrictions should be time limited. And other methods to maintain connection, such as video chats with families, should be facilitated. Next slide. And with that, I thank you for your attention to infection prevention and control and response efforts, and I will pass the presentation over to Dr. Janelle Ruth to discuss immunization considerations.
Thank you so much, Dr. Slifka. Good morning and good afternoon, everyone. I'm going to take a few moments to review immunization considerations in the long-term care community for both disease and outbreak prevention. The COVID-19 vaccine helps to protect from severe illness, hospitalization, and death, particularly in this population. COVID-19 hospitalization rates are 8 times higher for nursing home residents. CDC recommends a 2025-2026 COVID-19 vaccine for people aged 6 months and older based on individual-based decision-making, which is also known as shared clinical decision-making. In particular, this vaccine is especially important for your patient if they have never received a COVID-19 vaccine, is aged 65 years and older, has a high risk for severe COVID-19 disease based on other comorbidities, and is living in a long-term care facility, which is a standalone risk for COVID-19 disease. Getting a COVID-19 vaccine is safer and more reliable, a way to build immune protection than becoming ill with COVID-19 disease. Next slide, please. Routine annual influenza vaccination is recommended for all persons aged 6 months and older without a contraindication to the vaccine, ideally in the early fall, in order to protect against influenza and its complications. Both COVID-19 and influenza vaccine generally cut by half the risk of hospitalization related to infection by these viruses. Vaccination is particularly important in people who are at high risk of serious complications from flu, such as adults 65 years and older. And in fact, adults aged 65 years and older have the highest rates of flu-related hospitalization during most flu seasons. Also, people living in nursing homes or other long-term care facilities, and adults with certain chronic conditions, such as chronic heart and lung diseases like asthma and COPD, diabetes, severe obesity, kidney and liver disorders, and immunosuppression. Please note that the higher dose or adjuvanted influenza vaccine is recommended for those 65 years and older if available. Next slide, please. CDC recommends a single dose of RSV vaccine for certain adults to prevent serious RSV disease and hospitalization. These vaccines are approximately 70% effective in preventing older adult RSV hospitalizations in that first season after vaccination. RSV vaccination is recommended for all adults 75 years and older, and adults aged 50 to 74 years at higher risk for RSV, including those with chronic cardiovascular or lung diseases, severe obesity, diabetes, end-stage renal disease, hematologic conditions, liver disease, neurologic or neuromuscular conditions, immunocompromised, and also residing in a nursing home. In fact, 17% of hospitalized patients were long-term care residents in a population-based hospitalization surveillance system. RSV is not an annual vaccine, so people who have received one dose have completed their vaccination series and should not receive another dose at this time. Vaccination for RSV can occur at any time, but it is recommended ideally in the late summer or early fall months before RSV season begins in our fall months in most of the continental United States. And you'll note when I've been mentioning the chronic conditions, they're very similar across adults at greater risk for complications from COVID, influenza, and RSV. So these vaccines can be emphasized together when speaking with patients about immunizations. All three vaccines may be co-administered with each other and other routine immunizations like shingles and pneumococcal vaccines. If the patient does prefer to receive these vaccines separately, there's no minimum wait time between vaccines. So with that, thank you. And I'm now going to turn the presentation over to my colleague, Dr. Pragna Patel, to talk about treatment. Thank you.
Thank you so much, Dr. Ruth. So I'm going to go over treatment, and mostly I will focus on COVID and influenza because we don't have antivirals for RSV. So some considerations for COVID and influenza illness, you all know that they present with similar signs and symptoms. And so signs and symptoms are not enough necessarily to distinguish between the two. We know that co-infections occur. They're very rare, but it's good to keep in mind that they are possible. And the reason I'm emphasizing this is the literature suggests that people who are co-infected are at higher risk of severe disease. The decision to start empiric treatment is challenging, and I'm going to talk a lot about empiric treatment, particularly as it relates to influenza, because there's such a short treatment window for influenza. We're in a moderate severity flu season right now, and I think empiric treatment for flu can help us get on top of preventing some complications that would have occurred. It's also important to know what viruses are circulating in your area. So Dr. Slivka did show a slide of a dashboard that we've created that gives you an idea of what's circulating. So our SARS-CoV-2 circulates all year round. And of course, influenza is a fall-winter virus. So I do want to encourage you all to think about COVID all year. We've had summer surges and fall-winter surges, but low-level circulation throughout the year. It's important to take a thorough medical history of exposures, particularly in a facility if somebody that has contact with the patient is diagnosed with COVID or flu. That gives you an indication of what they may have. And I want to emphasize that a positive test result is not required for antiviral treatment for either COVID or influenza. But of course, testing can help guide treatment decisions. Next slide. So this is just a schematic, what we have normally done in the past. We see a patient with respiratory symptoms. We decide to test for pathogens. I want to emphasize that there are multiplex tests available now, and there are molecular tests, which happen to be very sensitive and can help distinguish between COVID and flu if you're in a situation where you don't know which pathogen the patient may have. And then we evaluate for therapeutic eligibility, and then we start the therapeutics. So just want to make sure that I emphasize that testing is optional. You don't need a positive test to start treatment, and that therapeutic eligibility step could actually be done with long-term care residents earlier, maybe when they enter the facility, so that there's no delay in starting treatment. And of course, people who are uninsured and underinsured can get free COVID-19 treatment through patient access programs. These programs remain active currently. There's a USG-sponsored program that will end December 2028. Next slide. So just wanted to talk about the advantages and disadvantages of different tests. So when should you test? Essentially, you should test when you have a patient with respiratory symptoms and you're not sure whether they have COVID or flu, because epidemiologic factors are not helping you to distinguish between the two. There are two types of tests: molecular tests, also known as PCR tests or NAT tests, and then the antigen tests, which are those commonly used rapid tests. The main advantage of the molecular test is that they're very sensitive. And so you basically can test as soon as somebody has symptoms, to distinguish between COVID and influenza. And that's another reason why I'm emphasizing the use of multiplex tests. The other advantage of molecular tests, particularly for SARS-CoV-2, is that you don't need to repeat the test to confirm the results. And this is a disadvantage of the antigen tests. They're less sensitive, which essentially means they have a higher limit of detection. You need to have a higher viral load in order for antigen tests to pick up SARS-CoV-2 infection, and therefore you can have some false negatives, particularly early in the course of infection. They improve their sensitivity at around 3 to 4 days after symptoms develop. So that's just something to keep in mind. Next slide. So moving on to antiviral therapy, they're a very important tool for the clinical management of COVID-19 and influenza. For COVID-19, they've been shown to reduce the risk of hospitalization, and for flu, they've been shown to reduce the risk of complications, as well as to shorten hospital stay. During this presentation, I'm going to focus on outpatient therapy because that's most relevant to long-term care facilities. Another important point I want to emphasize is that the decision to start treatment is based on an individual's risk of severe disease. And for COVID-19, this is an evolving space. CDC is actually in the process of conducting systematic reviews to understand risk of severe disease now that COVID-19 is endemic. But I will go through some general guidelines for assessing risk for severe disease. And also want to emphasize that antiviral treatment is recommended as soon as possible for any outpatient with suspected or confirmed COVID-19 or influenza who are at high risk of complications. So that's really long-term care facility residents, individuals who are greater than 65 years old, mostly the population that you're caring for in your facilities. Next slide. So this is a slide that's going over people at increased risk for severe COVID-19 and influenza. Dr. Ruth mentioned this in terms of the RSV vaccine. There are a lot of similarities for risk of severe disease for these respiratory pathogens, but there are also some nuances. I'm going to go over generally the guidelines that we think that you should consider in determining risk for severe disease. So age is the main driver of risk. Adults greater than or equal to 65 years of age are at increased risk of severe disease or influenza complications. And then there are certain chronic conditions like those listed here: cardiovascular disease, obesity, diabetes, chronic lung disease, end-stage renal disease, chronic hematologic conditions, chronic liver disease, neurologic or neuromuscular conditions, moderate or severe immunocompromise, all render someone at higher risk of severe disease. And for COVID-19, we're seeing that multiple chronic conditions increase somebody's risk of severe disease. You see here that residence in a nursing home by itself is also a risk factor. So for your residents, really, there isn't a question of whether you should consider treatment. And then there are other factors such as disability or limited access to healthcare. We've seen that patients who have chronic disease, but those diseases are not well controlled, are at higher risk of severe illness. Next slide. So I just wanted to go over the recommended COVID-19 treatment for outpatient therapy. There are 3 main antivirals that are available. Nirmatrelvir, ritonavir, also known as Paxlovid, is most commonly used. Very high efficacy in clinical trials. Just to remind you that those clinical trials were done among non-hospitalized, unvaccinated persons who had at least one risk factor for severe disease. Nirmatrelvir, ritonavir is recommended for persons 12 years or older. It's an oral medication given for 5 days, and it needs to be started within 5 days of symptom onset. There are a few considerations for this medication. You do need to adjust the dosing in some cases, and it's not recommended with severe kidney or liver disease. And there are some drug-drug interactions, mainly because of the ritonavir component. But I want to emphasize that ritonavir is not a new drug. It's actually been in use for more than 2 decades. And there are tools to help you understand drug interactions and to make that process a lot easier. And I'll point that out later. There's remdesivir had high efficacy in clinical trials as well, indicated for infants 28 days and older. And then it's an IV medication that's given over 3 days within 7 days of symptom onset. So it can be challenging because it's an IV medication. But remdesivir and nirmatrelvir, ritonavir are the 2 preferred options. Then the alternative option is molnupiravir. And the main reason it's an alternative option is that the efficacy in clinical trials was much lower, 30%. It's indicated for adults 18 years and older, but it cannot be used in persons of reproductive age. So you need to make sure that if you start someone on molnupiravir and they're of reproductive age, they also should take birth control. This may not be an issue for long-term care facility residents, but it is a limitation of the medication. It's an oral medication given for 5 days and needs to be started within 5 days of illness onset. And I want to point out that it's the only medication on the list that is still under emergency use authorization. It has not been approved by the FDA. Next slide. So I've gotten a lot of questions because the efficacy trials were done among unvaccinated persons. And so folks want to know, how good are these medications now that people are getting vaccinated and we have herd immunity from infection as well? So there has been a systematic review done of nirmatrelvir, ritonavir, mainly because it's the most commonly used medication and the data are available. And this systematic review of 23 studies over 300,000 patients included a meta-analysis, and it basically showed that real-world effectiveness of nirmatrelvir remains very high, can decrease the mortality rate by 75%, decrease the hospitalization rate by 60%, and the combined mortality or hospitalization rate by 83%. The other thing I want to point out is there was a clinical trial of using nirmatrelvir, ritonavir in people with standard risk of severe disease. So people who don't have chronic conditions, that 18 to 64-year-old age group that's relatively healthy. That trial showed that it was not effective at reducing hospitalizations and deaths. Next slide. So I'm just going to move to influenza. These clinical trials for COVID really did show that the medications keep people out of the hospitals and prevent deaths. For influenza, the antivirals tend to prevent complications and reduce hospital stay. And so what are the complications of influenza virus infection? And these can vary by age and host factors, immunity, influenza virus type, and subtype. But an uncomplicated illness basically looks like a respiratory tract illness. Folks may or may not have a fever. If you're dealing with the elderly, a fever should not be required to make this diagnosis. GI symptoms are common, but more common among young children. A complicated illness can affect any of the organ systems, and this schematic on the right of the slide can shows you that there are many organ systems that can be affected by influenza. But the main things that we're worried about are pneumonia, encephalopathy, exacerbation of any chronic disease such as heart failure and COPD. Next slide. So there are 4 recommended influenza antivirals for outpatient therapy. We have oseltamivir, has been around for a very long time, can be used in all ages. It's an oral medication. It's given for 5 days. The challenge with the influenza antivirals, you really need to give them within 24 hours of symptom onset. Baloxavir, it's a great drug. It's recommended for persons 5 years and older, another oral medication. It's 1 dose, so it's 1 day, so adherence is really high with this one, but it's not recommended for pregnant or postpartum persons. Peramivir is intravenous, can be used in infants 6 months and older. Again, it's a one-day medication, and zanamivir can be used for children 7 years and older. It's an inhaled medication, contraindicated in people with underlying airway disease. So it really does limit its use. There's an intravenous version of zanamivir, but it's not available in the United States. And I will point out from the questions that we received, only oseltamivir can be crushed and be used in NG tubes. Baloxavir cannot be suspended. There is a baloxavir suspension, but it's not available in the US. Next slide. So Dr. Slifka mentioned chemoprophylaxis earlier. I am going to refer to this as post-exposure prophylaxis because we have two types of chemoprophylaxis. There's pre-exposure and post-exposure. We're just focusing on post-exposure prophylaxis for influenza outbreaks. This is meant for people who are exposed to either high-risk persons without illness or signs or symptoms. Exposed persons such as long-term care facility residents should receive the antiviral. Basically, oseltamivir is our first choice, regardless of their vaccination status, to ensure that the influenza outbreak is contained. And you usually give post-exposure prophylaxis for 2 weeks. It can be extended until 7 days after the last case. So you can use this for a very long time. Oseltamivir is a benign drug. The main side effects we see are nausea and vomiting, which usually subsides after a few days of use. Extended PEP use in long-term care facility residents depends on a number of factors. So if there's an unaffected unit, but there's unavoidable mixing of the residents, if there's a situation where caregivers or healthcare personnel are going from affected units to unaffected units, we really recommend using an abundance of caution and going ahead and putting long-term care facility residents in unaffected units on post-exposure prophylaxis. It's a key component to control outbreaks in addition to other interventions in institutions that house residents. So it doesn't necessarily serve as a replacement for the vaccine, but it is a very useful tool in containing outbreaks. Next slide. So what's recommended for post-exposure prophylaxis? I highlighted oseltamivir, but there are 3 antivirals that do have an indication for post-exposure prophylaxis. So oseltamivir, baloxavir, zanamivir are the 3 that can be used for post-exposure prophylaxis. And one thing to point out is that oseltamivir and baloxavir actually have different mechanisms of action. And so they're very complementary medications and something to consider when you're making that decision. Next slide. So just want to summarize with key points from this section of the presentation. Antiviral therapy should be initiated as soon as possible in outpatients at high risk of severe disease to prevent progression of COVID-19 and influenza. Although a positive test result is not required to initiate antiviral treatment, testing can guide treatment decisions. I would like to emphasize that you go ahead and start empiric therapy if you're waiting for test results, especially in a situation that we're in now where it's a moderate, severe flu season. Molecular multiplex testing, we would like to recommend that for timely and accurate diagnosis if it's available to you. Nirmatrelvir, ritonavir is effective at preventing hospitalizations, and the drug-drug interactions can be managed safely. And there is no PEP for COVID-19. There is a medication that's under review by the FDA for PEP for COVID-19, but not PEP. But PEP is still used in institutional outbreaks for influenza and can be highly effective and should be considered in your armamentarium of tools to control outbreaks. Next slide. I think with that, I'm going to pass it back to Dr. West for our Q&A.
Thank you, Dr. Ruth, Dr. Patel, Dr. Slifka. Amazing information. Thank you for walking us through how to recognize, identify, and respond to respiratory virus outbreaks in long-term care facilities. Now I'm excited to get to some of our great questions that you, our audience members, sent in. First question I'm going to ask Dr. Patel, come back with you on this one. When diagnostic testing is not available, what are the best clinical indicators for choosing treatment for respiratory illnesses? So if you don't know if the person has COVID or flu, how do you pick?
Yeah, that's a great question. So I do think that there are a few things that you can use to help you decide. I mean, symptoms, as we discussed, they're not very useful in determining which treatment. So it's really important to be aware of what's circulating in the community and the individual risk of your patient. And that does include some epidemiologic factors, like who have they been exposed to? And if they were exposed to a case of flu or a case of COVID, that may sway you in one way, in one direction or another. Testing is it's not required to start antivirals, but obviously it's a great tool to help direct treatment. And we recommend using testing early in the course of illness to help you make these decisions. During community co-circulation of SARS-CoV-2 and flu, which usually happens in the fall and the winter, it's challenging to decide which pathogen a patient is infected with. So testing can be very important in those circumstances. Again, if flu is not circulating, I think making the assumption that it might be COVID is a reasonable assumption. Really important to start empiric therapy. I can't emphasize this enough, especially for patients who are at increased risk. This allows you to treat for flu within the indicated window, which is a very short window. So while you're waiting for the test results, go ahead and start oseltamivir. It's a pretty benign drug. Baloxavir, it's a one dose, and it really could help to save the patient from experiencing complications of influenza. The same holds true for COVID-19. I know folks are very reluctant to use nirmatrelvir, ritonavir. We have on the screen here the Liverpool COVID-19 drug interaction database. This, I would encourage you to play with it. It's such a great tool that can show you, what medications you need to stop or need to potentially change. It will give you recommendations as to what medications you can use. So it's a really nifty tool. And the other thing I will say is that empiric treatment for COVID-19 with nirmatrelvir, ritonavir, and then including empiric treatment of influenza with oseltamivir is fine. There is no drug interactions between oseltamivir and nirmatrelvir, ritonavir that we are concerned about. They can be prescribed together. They can be used safely together. The only thing to do is to ensure that you go through this step of making sure that there aren't any drug interactions with the medications that a patient normally takes, namely statins. They're commonly used, but also some of the blood thinners. And then it's really most important to make sure that people who are at increased risk get treatment early. And I just wanted to ask you to go to the next slide, because I know access of the COVID antivirals has been a challenge. They're very expensive medications because they've only recently been commercialized. But you can see here that the manufacturers and the US government all have patient access programs to help people who are uninsured or underinsured get access to these medications. And so I really encourage you to go to these web pages and understand from here what's described here, as well as on the web pages, what you need to do to get your patients the medications.
Thanks for sharing those resources. I know making sure that patients have access is really, important for us as healthcare professionals. And I will put a plug in for the Liverpool pages. They are fantastic, and they really do break down what exactly is the risk here. Is this an absolute contraindication, or are there ways to adjust maybe what the patient's on their other medications, so that you know exactly what you can do to help them get the antivirals that they need. Thank you, Dr. Patel. Dr. Slifka, I've got a question for you. When is the CDC going to update the COVID-19 infection prevention and control guidance?
Yes, I know that this is a question that many want answers to. Recommendations included in the COVID-19 infection prevention and control guidance were being reviewed as a part of larger guideline updates by the Healthcare Infection Control Practices Advisory Committee, or HICPAC. With the termination of that committee in early 2025, CDC is working to identify a process for updates to its guidelines moving forward. The draft recommendations regarding duration of work restriction for healthcare personnel with SARS-CoV-2 infection that were approved by HICPAC have not undergone public comment and therefore are not CDC guidance. But the evidence review that informed these recommendations are available online, and they have been used by some states and facilities to develop their own guidance. And then I'll also add that a similar evidence review is in progress to revisit the duration of transmission-based precaution for patients and residents with SARS-CoV-2 infection and the need for gown and gloves for caring for patients and residents with SARS-CoV-2.
Thank you for that. Another question for you. One of our audience members wrote in and asked, do we still have to test everyone for SARS-CoV-2 infection if we have a case in the facility?
So that approach remains an option, particularly if you have many cases, suggesting that you have widespread transmission in the facility, but it's often beyond the capacity of many facilities. However, depending on resources, it's also reasonable to focus efforts on symptom monitoring and mask use among exposed individuals, and then test those who develop symptoms. Whichever approach ultimately is taken, facility staff and residents should be informed when transmission is occurring and reminded of recommended actions to protect themselves and others.
Great. Another question that came in from one of our audience members was, my facility cares for pediatric patients in their long-term care facility. Are there additional pathogens beyond the three we talked about today, RSV, COVID, and flu, that are still a concern in this population?
Yeah, and I will go ahead and say the answer is yes. While we are talking in this presentation, and we talk a lot right now this time of the year about RSV, COVID-19, and influenza, they definitely play a big role in infections among pediatric patients, like I said, especially this time of the year. But there are other respiratory pathogens to consider that can cause similar symptoms and be as severe. Some of these pathogens are viruses like rhinovirus, enterovirus, seasonal human coronavirus, parainfluenza virus, and others. All of these can cause outbreaks in congregate care settings like nursing homes, and they have the potential to cause significant morbidity in children, especially if they have underlying medical conditions that place them at higher risk for severe disease. There have been several outbreaks related to adenovirus in pediatric nursing homes, which have caused challenges in controlling transmission, as well as pretty severe infections and even deaths among the affected children. Also, though, on the bacterial side, there are two additional pathogens that can look like viral respiratory infection and have the potential for outbreaks. These are pertussis, or whooping cough, and Mycoplasma pneumoniae, sometimes referred to as walking pneumonia. These can also cause severe disease in children with weakened immune systems or underlying risk factors, which are common in pediatric long-term care. So from an infection prevention standpoint, the same core infection prevention practices like respiratory and hand hygiene, or washing your hands, good cleaning and disinfection of the shared environment, source control, use of transmission-based precautions, these all help to reduce pathogen spread and prevent infections in nursing homes, including pediatric nursing homes. And you can find additional information about these pathogens, including vaccine recommendations where applicable, on the CDC website.
And that's, I think, one of the benefits of those multiplex platforms is that sometimes you can roll in some of these other pathogens into this, in the testing milieu, when you have platforms that can test for multiple different pathogens.
Yes.
Another question that came in, we touched on a little bit earlier, because a lot of facilities have, shared rooms, people have roommates. Can a resident with symptoms of a viral respiratory infection remain in the shared room with a roommate?
Yeah, so, we say when available, residents should be placed in single-person rooms to minimize the risk of transmission to roommates. But moving residents to a single room is often not practical because, for example, there's limited availability. And so in those situations, residents can remain in their room, in their current location, but with additional steps taken to try to limit transmission in the room. And so I know I mentioned earlier the use of in-room HEPA filters or HEPA air cleaners to increase ventilation, and then separating the resident beds as far as possible from one another, and then using a curtain and pulling that curtain in between those residents. Symptomatic residents should not be placed in a room with a new roommate unless they've both been confirmed to have the same respiratory infection. That ill resident should remain in their room, and if they have to leave the room, ideally should wear a mask if they are able to tolerate doing so. And then, as I said earlier, roommates of that symptomatic resident who have already been potentially exposed and could become infected should not be placed with new roommates. They should be considered exposed and wear a face mask for source control around others.
Great. Question about NHSN. So are there updates for how facilities should define up to date as far as COVID-19 vaccination when they report to NHSN?
And I can share some information from our NHSN colleagues. We are all very appreciative of your patience with the COVID-19 vaccination definition and updates. It is anticipated that the COVID-19 vaccination materials will go live on CDC web pages by the end of January 2026, so the end of this month. The NHSN materials will align with the COVID-19 vaccination guidance that's on the CDC web currently. And so what that would be is that individuals aged 65 years and older are up to date when they've received 2 doses of the 2025-2026 COVID-19 vaccine, or they've received 1 dose of the 2025-2026 COVID-19 vaccine in the past 6 months. So to give you an example, if you have an individual who is 65 years old and received their first dose of the 2025-2026 COVID-19 vaccine on October 1st of 2025, they would need to receive their second dose after April 1st of 2026 to remain up to date with COVID-19 vaccines. Individuals who are younger than 65 years are up to date when they've received 1 dose of the 2025-2026 COVID-19 vaccine anytime since it was approved in August of 2025. For more information, once this is all posted, the up-to-date definition for each quarter is found in the Understanding Key Terms and Up-to-Date Vaccination document, which is on the NHSN web pages. And like I said, it is expected to be updated by the end of this month, January 2026.
Thank you. I think we've got time for one more quick question. What duration of isolation is recommended for residents with RSV during a facility outbreak?
This is a question that we also have received from many. So what I will describe is that I will mention again, I mentioned this earlier during the talk, but recommended infection prevention precautions for patients with RSV as well as other specific pathogens are addressed in our guideline for isolation precautions. This is Appendix A that I mentioned earlier. So standard precautions has historically been recommended for adults with RSV. So this would include using gloves if you're anticipating contact with respiratory secretions, and a face mask for source control on the patient or resident, and protection of the worker in anticipation of coughs and sneezes. But because nursing home residents are at higher risk of severe disease if they become infected with RSV, we generally recommend including them in the category with infants, young children, and immunocompromised adults. This would mean placing them in contact precautions and also having residents wear a face mask for source control, of course, if they can tolerate it, and having healthcare personnel wear a face mask and potentially eye protection in anticipation of coughs and sneezes. The recommended duration of precautions would be the duration of illness for most of these residents. There have been some shedding studies looking at PCR, not culture, that have typically seen viral shedding for about 10 to 13 days. And then I will just add that there are other references on the CDC webpage. You can refer to those for some additional guidance on the background of why contact precautions was specifically recommended for RSV.
Thank you. I want to say, thanks to CDC guests. It's been great to focus an hour on the challenges and opportunities that exist in long-term care facilities. I want to thank our audience for your great questions and for your commitment to caring for people in long-term care facilities. If you're interested in continuing education credit, you will see a button on the AMA Ed Hub page under the video to take you to train CDC's CE system. We appreciate your willingness to spend time with us today and for all you do to keep long-term care residents safe and healthy. There will be a video available right here on the AMA Ed Hub page. For those of you that are coming in late or had to leave early, you can come back and finish watching at any time. Thank you all and have a great rest of the day.